Good morning. Welcome to Your Health with the Hutchinson Clinic. You can hear us the first Saturday morning of each month. I'm Dr. Tim Prater. I'm an internal medicine doctor at the Hutchinson Clinic, and I also work in our clinical research department. With me is Dr. James Ruhlmann, also the internal medicine department at the Hutchinson Clinic, and he does research too.
Good morning.
During each episode, we'll visit with a physician or provider from the Hutchinson Clinic. Every month we'll feature a new topic that might affect our listeners. I'll introduce today's topic right after we talk about some clinic news. The Hutchinson Clinic has extended hours for walk-in care at our Waldron location. No appointment needed. Come in anytime Monday through Friday from 7:30 a.m. to 8 p.m. These extended hours will allow you to get care more conveniently. In addition, we also offer family practice appointments in the evening for people who can't come in during business hours. Call 620-669-2500 to make an appointment, or go to hutchclinic.com.
I'll tell you, Tim, that's an important service that they provide. It's a good service. I think they do a good job down there.
I do too. I think they do excellent work, and it's nice to have that extra time, people getting off work and can't come during regular hours. Today we're going to talk about internal medicine. Many people don't understand the difference between internal medicine and some other specialties such as family practice. So we want to talk about that, talk about training, specifically, Dr. Ruhlmann, about your training, what you treat, and some of the symptoms that would indicate the need for an exam, how you work with other specialists at the clinic, and then last but not least, how to make an appointment.
All very good, very important questions. I've been doing this now 23 years. I've been at the Hutchinson Clinic for 23 years. I came out of residency in 1995. My first job was in Hutchinson, Kansas, and it has been my only job so far. I'm very fortunate, very blessed to have to be here. In my time in the community, a lot of people, high schoolers usually, come up to me and ask, "I want to be a doc. What do I have to do to be a doc?" And it's a good question. I think a lot of things are involved in it. Number one, you've got to have the aptitude. You have to be able to absorb large volumes of information rapidly. And Tim, I'm sure that was your experience as well.
Oh, yeah.
In medical school, it's a lot.
It's like drinking from a fire hose.
It is definitely drinking from a fire hose. So the first step, you got to go to college. You have to go to college. You got to go to a 4-year college. You have to complete a degree. There are all sorts of prerequisites that you have to have completed before you can even apply to medical school. When you're in your junior year of college, you're going to take your MCATs. It's a standardized test that they administer to everybody who's even thinking about going to medical school. You take your MCATs, you go to your classes, you do well, and you need to do fairly well if you're thinking about a career in medicine, and then you apply to medical school. Once you've been accepted, you go to medical school, and that's a 4-year process. Your first 2 years generally are classroom work, where you're learning all of the basic sciences that go along with the human body. The heart, the lungs, the kidneys, the brain, how all of these interact. The amount of detail you go into is amazing. It's immense. And so you do that for 2 years. And your third and fourth year generally are clinical years, where you are rotating through the various specialties of medicine. You'll rotate through OB, you'll rotate through pediatrics, you'll rotate through neurology. You'll just go for a month at a time generally and experience all of these different facets to medicine. And from that, kind of get a feel as to what you like. And obviously, during the whole time, you're being graded. It can be a little nerve-wracking, obviously. You're being evaluated the whole time on what you're doing, not just through tests, but just through your interpersonal skills. Something as basic as that is how you greet a patient. I remember one of my attendings in my third year, I was practicing how to do a physical exam, and he really liked the way I greeted the patient. That was a big deal for him. So it's all of that goes into the evaluation of how are you rating as a physician among your peers, and realize these aren't just general population peers. These are highly selected groups of people that are also high achievers and academically high achievers. So you're being rated among them as well. So you go through that, and then hopefully from that you can get an idea as to what you like to do. What sort of medicine do you like to do? It's somewhat of a process of elimination. I had a little bit of a problem when I was in medical school because I liked everything. I enjoyed all of it. I enjoyed all of my rotations. Maybe with one exception. I'm not going to tell you which one that was. But maybe with one exception. But I enjoyed generally all of my rotations. I really thought about going into OB. I thought about pediatrics a lot. But eventually you decide on what you want to do, and then you apply. And there's a thing called the match, where they take your choices, they take the residency's choices, and they put them together and decide what the best match is for everybody. And from that, well, now you've kind of committed yourself to a career path at that point. So you've done 4 years of college, you've done 4 years of medical school, now you're going into your residency. And that can be anywhere from 3 to 5 years, potentially more, depending on what you opt to do, if you opt to do a fellowship or subspecialize even further. In our case, for Tim and for me, it was a 3-year residency. You start off as an intern, and I don't know what your experience was like, but my experience as an intern, I knew nothing. I mean, it is terrifying.
You show up and you don't know as much as you think you do from being a medical school graduate,
no
but you
question.
found out very quickly how little you know.
Yeah.
And that's a lot of about that's one of the big things about medicine, is not just your knowledge base, but knowing what you don't know.
Oh, absolutely.
And when to get help. And those are that's what you learn in residency.
Yeah, and your first year of residency, you don't know much.
Yeah.
You've still got the MD behind your name, because you are an MD. You are a doctor now.
Yes.
But all of a sudden, when you give an order, nurses are doing it. And that is
sobering.
Oh, it is definitely sobering. It is a totally different dynamic. So you go through your 3 years of residency. Your first year is your internship. Your second and third year, you're doing more rotations. And again, I had the same kind of a problem where I kind of liked everything I did. I enjoyed rheumatology. I enjoyed nephrology. I enjoyed cardiology a lot. But to be honest, at the end of college, at the end of medical school, at the end of residency, I was ready to be done. I was tired, residencies back when you and I did them were different than they are now. There were no hour limitations. They would just work you and as long and as hard as they wanted to,
Until the work was done.
Absolutely, and you didn't go home until the work was done.
Right.
It wasn't shift work.
Nope.
So I was done. I was tired, and I really needed to be out. Had a wife and 2 small kids at that point, and frankly, I needed a paycheck. So I go through all of that just to tell you, it is a long, drawn-out process. And when I'm talking to high schoolers that say, hey, I want to be a doc, what do I have to do? Well, number one, you got to have the mental aptitude to do it. And a lot of them do. And number two, you better have the drive to do it. Because it's not something that you're just going to do on a whim. If you don't love it, you will hate it.
Yep.
It's that simple.
That's for sure.
So that's what it takes to be an internal medicine doctor. 4 years college, 4 years medical school, 3 years residency, and then they unleash you onto the world.
Yeah, that's the truth. I was just talking last night to my wife about this, and the 3 things that I think we got the lecture about, the 3 A's of success in medical school. Ability, obviously. Availability, if you're not there, you can't learn it and you won't experience it. And affability, how well do you get along with the team? So, there are not a whole lot of lone rangers on a medical team, especially in a big university setting like the one you were at Iowa. And so you have to have all of that or you won't do well.
Yeah, absolutely. And it's got to be a team approach. And they always said, you better be nice to your nurses because your nurses can make your life hell.
That's the affability part, definitely.
Absolutely.
You better be nice. Yeah, you're right. And the responsibility that suddenly just kind of devolves onto you when you're an intern is kind of interesting. I had a friend, we were called to a code at this big university hospital, and we go in the room, and this person was very sick and dying, and he shouted at the nurse, quick, get a doctor, and she said, you are the doctor. And that's when he and I both thought, oh, this is this is serious.
Yeah, it is.
Yeah.
It is.
But then you just take over and do what you're trained to do.
Yeah.
You get used to it.
Yeah.
That first baptism by fire was something else.
No question.
And no, I'm not the one who said somebody get a doctor. I knew it. But it was funny.
Yeah.
Well, So we've talked about the 11 plus years of training after high school to get to be a physician, and then after you finish your residency, most people take a board examination of some sort.
Correct. Yes.
Let's talk a little bit about that. What is that? What?
Well, in your residency, like I said, when you and I did it, the hours were not limited. You just worked until the work was done, and there was always more work to do. At the end of your residency, there's a national board exam that you have to take that covers everything that an internist could potentially see in their practice. And the hope during your residency is that you've gone to a residency where you've seen enough variety that you, somewhat by osmosis, pick up what you're supposed to do for each of these disease processes, for each of these clinical conditions. In addition to that, so you finish your residency in end of July, the board exam is October, November. So you've got a couple of months there where you better be studying, because this is not an easy test to take. It's a lot of material that you have to master and you have to memorize. So I know it was the case with me. When I finished my residency, I took about a month off and studied. I don't know if anybody was here during the mid-90s, but I was the guy in the library at Hutch Library here on Main Street. I was the guy in the library for about a month studying.
Yeah.
That was me.
Yep.
Well,
and that's just the first step, becoming board certified, and it is an important step. It's not the only thing, but it is something that kind of stamps you as a person who has the requisite knowledge base
yes.
to be a successful internist. You had an idea of what kind of doctor you wanted to be. Who were your role models? What kind of people did you look to kind of get that idea of what it means to be a doctor?
I think everybody has role models, and I think to some extent you choose your specialty by who you identify with the best, who you identify with the most. I know Gerald Mins down at KU Wichita. He's been down there forever. He was someone I looked up to a lot. Brilliant man, incredible clinician. He just knew what was going on with the patient, and there was never a topic you could stump him on, ever.
Let's get back with him after we take a quick break, and we'll talk some more about that. All right, this is Dr. Tim Craner, back with Dr. James Ruhlmann. We're talking about medicine in general, training, and then internal medicine, which is what he and I both do. James, we were talking a little bit before the break about one of your role models, Dr. Mins, who is an outstanding internist at the University of Kansas. Can you tell us a little bit more about him or about how he influenced you?
Well, I was fortunate enough to have a rotation with him during my third year of medical school. It was a general rotation for internal medicine at the VA hospital. And like I said before the break, I think you really kind of gravitate toward those people that are maybe most likely like you, or people you most want to emulate. And he was someone I wanted to emulate. I wanted to emulate. He was always calm, cool, and collected. I mean, it didn't matter what was going on. You just could not perturb the man, which I thought was admirable, a very admirable trait for a physician.
Absolutely.
And then, like I say, he just had this incredible encyclopedic knowledge that just floored me. And I think I had physicians, by and large, we're all introverts. We just are. We're all nerds. And for me, that he was like King Nerd. Gerald, I hope you don't take that offense at that.
No, he was a walking encyclopedia of medical knowledge.
Yeah, and I enjoyed that. Enjoyed just sitting at that fountain, learning from that. It was very eye-opening for me. And I'm going into it thinking, this is what an internal medicine doc is like. This is what medicine is supposed to be like. And this is what I like so much about it is here's this patient. They come to you. They have complicated, complex, multiple medical problems, and you have to sit there and figure out, first off, what do they have? And secondly, how do you treat it? How do you make them better? How do you get patient from, in the hospital bed, not doing well, to going home with family. How do you get from point A to point B? So you've got to figure out what they've got. You've got to take the clues. You've got to take the puzzle pieces, and you have to put them together into a diagnosis, and then from that you have to formulate a treatment plan. Step A, B, C, all the way to whatever it takes to get them up and going and out of the hospital. That intellectually appealed to me a lot, and that's, I'm sure, why I ended up going into internal medicine. He was definitely formative for me in terms of how I view medicine in general, how I view the practice of medicine.
I think that yeah, and I don't think it's any coincidence that Sherlock Holmes was written by a doctor. That character came from Arthur Conan Doyle, whose idol was a physician in Scotland.
Correct, yeah. Joseph Bell.
Yes,
that's right.
An incredible diagnostician. So medicine is a lot like, detection of other kinds. It's putting together the pieces of the puzzle for the patient. And so, yeah, I agree with that 100%. When we talk about internal medicine versus other things, how do you set yourself apart, or what's different in your mind, internal medicine, obviously, versus other things?
Yeah, that's something I run into a lot. A lot of people don't necessarily understand what's an internist do? What's an internal medicine doc? What's that mean? You've got your primary care specialties, and that generally, when you look nationwide, that's considered to be family practice, pediatrics, internal medicine. Sometimes OB is thrown in there as primary care. But in family practice, say for instance, they will have a training program that is more geared toward the outpatient. They treat a wider age range, so they'll treat everybody, exactly. They'll start with newborns all the way up through 109. They will also treat pregnancies. They will not in our community, but in a lot of communities, the family practice doc is the doc that's delivering babies. If it's an uncomplicated delivery, they will be the one that's the attending that signs the birth certificate, and then many times they will be the one that in years later will sign somebody else's death certificate. So it's the full spectrum, but it's maybe a little bit more broader view that doesn't let them get into the depth on specific diseases. So toward that end, you've got two other primary care subspecialties or specialties. One would be pediatrics, where obviously they're treating children. So anybody up to age 18, and children as they develop they're different. It's definitely different than taking care of adults. It's there's all sort of developmental issues that you could potentially have to deal with. So they are their own specialty, pediatrics, and they will take care of children. We as internists, generally I'll start seeing a patient at about age 16. Some will cut it off at 18, but 16 to 18, somewhere in there, we'll start seeing them when there's more of an adult physiology that's going on. Because of our training, we are, I would say, well-versed in all of the disease processes that happen with adults. And again, that's multiple organ systems we're talking about. You talk about lungs, heart, kidney, liver, brain, urinary, everything. So we have a much more in-depth knowledge of the disease processes that go along with those. And I think that our training allows us to be the Sherlock Holmes. Our training allows us to take someone with complicated diagnoses or multiple different symptoms and unify them into a diagnosis that makes sense, that can then be used to map out treatment. So the difference is, family practice, you're treating all ages. Pediatrics, you're treating children, and we're treating anywhere from 18 to, like I say, 109. So it's still a broad range, but you don't have the developmental issues that you do with, say, pediatrics.
Yeah, I like it because you can really, like you said, zero in on a subpopulation of people, adults.
Yes.
And, you can try to gain some level of mastery over this enormous amount of information, and just focus on adults. I like, it's the chronic, it's chronic diseases, it's acute, things that all of a sudden there's a problem. And then, it's the long-range things related to aging.
Absolutely, yes.
And diabetes and those other types of chronic diseases that really make it a challenge and make it really interesting. And that's probably the main reason I decided to do that. I too had a mentor. There was a hematologist in Kansas City who was just an incredible diagnostician, and he saved a whole lot of cases, and he would present them to the medical students and ask us to figure it out. And that's when I really got a flavor for the pursuit of a diagnosis.
Yeah,
and
yeah.
how interesting that can be.
It is, and it's really intellectually gratifying when you come up with the diagnosis and you're going down this trail. Say, I just had a patient not too long ago with an anemia, it was an unexplained anemia, and it's like, well, why on earth would this be? They're young, they're healthy, they exercise. Why would they be anemic? And so I order some more labs, which prompts me to order some more labs, and eventually we came down to the correct diagnosis. But it's gratifying because, number one, I know what it is, but number two, I know what I can do about it. I can help this person with that now. There's something we can do about it. So it's not just a futile intellectual exercise. It's an intellectual exercise that actually has results, that actually has impact in the here and now.
That's what I like about our clinic, is that we can bring a whole lot of technology to bear for diagnosis.
Absolutely,
and then we also have a broad spectrum of specialists for treatment.
Yes.
So that's the great thing about the Hutchinson Clinic, I think, is that we have technology, we have the ability to make the diagnosis, and then we can keep the patient right here in Hutchinson for complicated treatments of all kinds.
Yeah, I completely agree with that. And we recruit a lot of physicians, obviously, and I always tell internal medicine or family practice docs that we're recruiting, I always tell them, look, you are never operating without a net here. You always have somebody that has your back. You can always pick up the phone and call somebody and say, hey, look, I'm having trouble figuring this one out. Can you help me? Or, you know what, this patient looks really sick. Can you help me out with this? So it's an excellent formula for taking good and prompt care of the patient. And I'll tell you another little piece of that, just I guess from my own experience. I'm from the East Coast. I grew up in Baltimore, and all my family lives on the East Coast. And so if anything, and I'm the only physician in the family, so if anything happens medically, guess who gets called? I get called, and they say, hey, your mom's got this going on, or your brother's got this going on. What do you think? And I'll kind of walk them through what the possibilities are, what the potential workup is going to be. And it astounds me every time how long it takes for them to get procedures done, how long it takes for them to get studies done. If someone needs a CAT scan, it's weeks. It's weeks. We'll do it the same week, same day sometimes if we need to. I can call up the radiologist and say, hey, can you fit this person in? And they do. So workups that on the East Coast take weeks to months, we'll do in a week.
Right. They'll say, Dr. Crater would like to have this done. Well, in a bigger place, they'll say, well, who's he?
Exactly right.
Here we get things done.
Right.
So that really is that's a real plus. So that really kind of is the spectrum of primary care versus internal, breaking it down to three main categories. Let's talk a little bit about our department. We've just got a little bit of time left. We have a new physician coming.
Dr. Sarah Patry, we're looking forward to her coming.
Yes, it's going to be great. She finished her chief resident year down in Wichita, and
which is an honor, by the way. To be selected as chief resident is a big deal.
It is, and so it's great that we're going to have her on the team. That'll put us at 5 internists.
Correct, 5 internists and 2 nurse practitioners.
Mm-hmm. So we're really excited about the team we have, the quality of the physicians and providers that we have, and think that we're going to move forward and do really well as a group.
I think it's a good thing. I definitely think it's a good thing. I'm excited to have Sarah show up. Recruiting outpatient internal medicine docs is a little bit hard. And this is something we're going to talk about, I know, in the future, the hospitalists and hospital medicine and what that means.
Yes. And we're always taking new patients, by the way, in the internal medicine department.
Absolutely.
So just to wrap up, I want to tell everybody to tune in next month. We'll introduce Dr. Patry. She'll come in and talk to us a little bit. But that's it for today. Thank you for listening to the Hutchinson Clinic Internal Medicine. You guys, go on. Appreciate it.
Thank you very much.